guess I do. Hello, I'm Professor Timothy Carey, the Director of the Institute of Global Health Equity Research and the Andrew Weiss Chair of Research in Global Health at the University of Global Health Equity in Rwanda. The Research Institute is a really exciting initiative of UGHE as part of a master plan to reimagine health professions' education, research and research training with the ultimate aim of eradicating global health inequities. I'm super delighted to be hosting this webinar. The idea for this webinar, which we'd like to turn into a series of webinars, emerged from discussions with my colleague, Dr. Charlotte Hanlon, who's based in Ethiopia and linked to Addis Ababa University and King's College London. From those initial conversations, we've worked together to develop what we hope will be an interesting, maybe challenging, and very useful 90 minutes of sharing information and expertise. One lesson from the COVID-19 pandemic that may not yet be fully appreciated has been the immense value some jurisdictions have derived from the systematic and sustained collection of data, along with their willingness to base decisions on the data being collected. In the area of mental health, however, the potential value of collecting data in a routine and organised fashion and basing service delivery decisions on those data has not been exploited. So, in this webinar hosted by UGHE in collaboration with CDT Africa at Addis Ababa University and the Centre for Global Mental Health at King's College London, we've been fortunate to assemble a panel of global experts to explore ways to improve the routine use of data around mental health for policy and planning, and in response to the COVID-19 crisis. Drawing on their own expertise, they'll discuss the need for locally available data to improve decision-making at district, regional, national, and cross-national levels to address the inequities in service provision for people with mental health problems in resource-poor settings. So, over the next hour or so, you'll be hearing from Professor Shekhar Saxena, who's Professor of the Practice of Global Mental Health at the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. A psychiatrist by training, Professor Saxena was in the faculty of AIIMS, New Delhi, before he joined the World Health Organization in 1998. From 2010 to 2018, he was the director of the Department of Mental Health and Substance Abuse at WHO. During his leadership, WHO's Mental Health Action Plan was adopted by the World Health Assembly, and mental health and well-being was included in the United Nations Sustainable Development Goals. Charlene Sunkel is the founder and CEO of the Global Mental Health Peer Network and former principal coordinator for the Movement for Global Mental Health. She has published widely on issues related to mental health and human rights, stigma, and the needs of people with mental illness in low and middle income countries. She's currently co-editor of the Lancet Commission on Mental Health Stigma and Discrimination and a commissioner on the Lancet Commission on Psychosis. She was diagnosed with schizophrenia in 1991, and her journey since then has exposed her to the challenges experienced by persons with mental disorders within and outside of the mental health sector. She now commits herself to fighting the cause for mental health and human rights. Professor Oye Girije is Professor of Psychiatry at the University of Ibadan and Consultant Psychiatrist at the University College Hospital, Ibadan. His research focuses mainly on epidemiology, global mental health, and health systems strengthening. He has also been active in the area of nosology and the classification of mental health conditions. He chairs the National Mental Health Action Committee, which is a policy think tank of the Nigeria Federal Ministry of Health, and is a member of the Ministerial Expert Advisory Committee on COVID-19. And Dr. Yvonne Kayatashonga is the Mental Health Division Manager at the Rwanda Biomedical Centre. She's a practitioner in the field of clinical psychology and a public health professional with 26 years experience, including as Director of the National Mental Health Outpatient Centre, National Director of all Mental Health Services, and National Director of Mental Health Division. During a PhD scholarship grant, she began researching on the evolution of trauma among the survivors of the genocide perpetrated against the Tutsi, and has since researched in the trend of trauma, other mental disorders, drug addictions, and resilience in the Rwandan population, with a particular focus on genocide survivors. So an absolute stellar lineup of experts, and I can't wait to start hearing from them. Before I do though, before we do, just a couple of housekeeping matters. There will be a question and answer session at the end of the 4 presentations. So please remember to, anytime a question occurs to you, pop it in the question and answer, and we'll get to those at the end of the 4 presentations. This webinar is being recorded and will be distributed on all of the UGHE usual channels and social media and so on. So look out for that as well. Okay, so without any further words from me, let's move to our first speaker, Professor Saxena.
Thank you very much, Tim. I'm delighted to join you and other panelists for this webinar, which is on a subject that is extremely important, not only for the African countries, but for the whole world. And I'll present in the next 10 minutes a few thoughts just to begin the conversation. And I would like to focus on what you already mentioned, the importance of data for policy, and from local to global, and how it also works the other way around, global to local. If I can have the next slide, please. There are a couple of points that I want to make right in the beginning, that mental health data is important for several other purposes, but we should focus for the current discussion on its usefulness for policy and also for practice. How does policy advance the objectives of mental health for the populations, and how does practice advance it for the people who are being assisted? Generally, as Tim, you already mentioned, data in the area of mental health is extremely deficient all over the world, but also from African countries. And that is a problem that has existed for many decades. It's becoming a little better, but still there is a lot of deficiency. And during these times when we have data on some other health aspects, especially on the COVID pandemic, which is abundant and is current and is being used a lot in policy, it's especially a glaring gap in the availability and also in use of data for mental health. And this is perhaps as good a time as any to correct that gap. And so I think this webinar comes at a very, very important juncture of time. My next point is that some data is, the previous slide, please. Some data is better than nothing. Obviously, that is a rule everywhere. But also let's remember that wrong data can lead to wrong decisions. So we need to really rely on data that is accurate, that is timely, and is correct. So there is no point collecting data which is wrong, because then it is counterproductive and can actually lead to problems. And as I explained earlier, there is this virtuous cycle, if I can call it that, from local to global, because most of the data, not all, arises from local situations, from people, from populations, and then it aggregates to the regional level, to national level, and to global level. But it's also important to look at the other side, that global trends and global definitions of outcome measures on the limits of data, the definitions of data, should actually percolate down to the local level, so that there is comparability across countries and across time. which is equally important. Obviously, it is worth noticing that most of the use of the data should be at a local level, so that we need to emphasize that use, but it does benefit from a global discussion. Next slide, please. I'll give you some examples of the kind of data which I find extremely useful. And the first which comes to my mind is the WHO's Mental Health Atlas, which was begun in 2001. And since then, there have been 5 editions in 2001, 2005, 2011, 2014, and lastly in 2017. And this has become one of the major sources of data on mental health from countries. These publications have been enormously useful for people in the civil society, people in academics, and obviously people within the governments. And these accumulate data from all countries, all regions of the world, and compiles the information into tables, which are extremely useful for comparison purpose, but also gives country profiles. So there will be a profile from Rwanda and one from South Africa and so on, which are again extremely useful. There are limits to the data that Atlas can gather and publish, but still that's a good example of the local to global and also then global to local. All of these uses are extremely important. This is one of the major contributions of WHO over the last 2 decades. The next slide depicts one of the very recent contributions from WHO, which is the impact of COVID-19 on mental, neurological, and substance use disorders, just published a couple of months back, where there is information from 130 countries, 28 are from the African region. And it turns out that mental health and psychosocial support is included as a theme in the plans by a vast majority of countries. But the funding is actually provided only by a small minority of countries. So this is the kind of use of data which is extremely important, that majority of countries are keeping mental health in mind as they plan for the response to the COVID, but a very small minority of countries are actually putting the funding there, which is one of the problems that mental health has faced for a long time, but we need to correct that. I will illustrate in some of the next slides things that I find very useful. For example, the mental health and neurological and substance use burden. All of us know about the high amount of burden because of these conditions, but this slide actually depicts another point, that the vast majority of that burden actually begins in the early adulthood, between the ages of 15 and 35, which is enormously important for policy, because we're dealing with people who should be contributing to the society in terms of their social and economic value. And this is the time period when they get affected by these conditions and have compromised capacity to contribute. This is extremely important for ministries of health and also ministries of economy. Next slide depicts another facet of this, which is, Tim, directly dealing with the issue of equity. Excess death amongst persons with severe mental disorders is shorter by 15 to 20 years. This is how we're dealing with this group of people who actually live a life which has a low quality of life, but also the quantity of life is compromised and they die much earlier than other people. This is a solid point for policy intervention. Next slide depicts another point, which is on the economic side. You will see the figures on the slide are lots of zeros. You can't even count them. This is 2.5 trillion, the cost of illness, direct as well as indirect, in the year 2010, and increasing up to 6 trillion by 2030. Now, this is directly useful for countries, that the mental health is not only a disability, it's a direct drain on the economic development. Next slide shows you another aspect of it, the gap between the burden, which I showed earlier, and the budget. And this is true for all countries, low income, middle income, and high income countries, that the burden is high, the darker lines, and the budgets are very small. In fact, for low-income countries, you can't even, it's difficult to see that bar. And that is the point that I repeatedly make to policymakers. And it seems it's worth noticing. And all of that is because somebody down there locally collected the data, and then it gets aggregated into these kind of global figures. Next slide. It shows the treatment coverage. The result of all of this low investment is that the vast majority of people do not receive the treatment that they need to receive. And again, the figures are very telling. In low-income countries, less than 5% of people with major depressive disorders who receive treatment. In middle-income countries, it's about 10–11%. But even in high-income countries who pride themselves in their mental health systems, countries like USA, Australia, Scandinavian countries, they have less than 1/4 of these people receiving adequate treatment. This is an eye-opener in how we are treating these people. And this is something that we need to use much more for this purpose. In fact, this slide tells me that we should be using this phrase very often, that when it comes to mental health, all countries are developing countries. Next slide. It shows again another aspects of the economic side, the depression that I have depicted earlier in terms of treatment gap. Actually, the return on investment are very high. This is work done by some of my colleagues and myself, that if you count the direct as well as indirect costs and the returns, direct as well as indirect, then on an average, you get back at least $5 out of each dollar that you spend. So it's not that investment in mental health is going down the drain. It actually gives you a lot of returns. And currently, when the interest rates are very low, this seems like a very, very good investment into society, into people, and into the economy. Next slide. And finally, another slide which shows you by graphic means the disparity between the burden and the investments, this time by the development assistance of the whole world. And you see in green the burden on top because of HIV, and because of, in orange, because of mental health issues. And on the bottom side of the slide, you see the investment made by the development agencies, which is for HIV in green and for mental health in orange. You see the disparity, how we are dealing with different conditions in a very different way. And that brings me to my summary points. Next slide, please. We need to really use data in a smart way at all levels, local, national, and global level. And we need to integrate data collection in the routine health information systems. That's the only way to collect reliable data, which can be used at all levels. And there I want to make a point that we tend to, often we don't collect data, but when we start collecting data, we collect too much, which is sometimes not of great use. So less is better, but accuracy and timeliness is really, really important. We also need to use indicators which are actionable. Yes, it's important to open the eyes of people, but it's much more important to tell them what they can do about it. So that is really an important point. We need to provide timely and understandable reports. Very often scientists produce reports which the policymakers don't want to read. If they read, they don't understand. If they understand, they don't know what to do about it. All important points to remember. We also need to have data in such a manner that it's comparable across time and regions. Very often the Minister of Health says, okay, what is the next country, neighboring country doing? Are they better? Are they not better? And that's really very important to kind of have a healthy competition between different countries and also across time, whether you're doing better today compared to last year and the year before. And finally, use of data as in an effective manner with multiple stakeholders. It's not only the policymakers, but also academics, the civil society, people with lived experience, because eventually policymakers listen to their voters, and all of this affects them either directly or indirectly. Thank you very much for your attention, and back to you, Tim.
Thank you, Shekhar. Wow, that was a real lesson for me in how much amazing information you can pack into a small number of slides. That was just incredible. One knockout slide after another. I don't know whether it would have been worth emphasizing. I love your idea of the virtuous cycle. It's something that I don't think we pay enough attention to data, full stop, but that idea of the interplay between local to global and back again is just fantastic. And the idea of the difference between the burden and the budget was just staggering. How people cannot be paying attention to that when you look at the return of investment information as well is just unbelievable, but it's been going on for a long time, which again underscores the importance of initiatives like this and the use of data, and also your point, Shekhar, that it's important to be aware of the limitations of data so that the decisions that we're making are sound. Okay, you've got us off to a flying start. We'll move over to Charlene now. I'm really looking forward to your perspective, Charlene. Over to you.
Thank you very much, Tim. Very excited to be part of this and to join my fellow panelists in this discussion. I'm just going to start off by capturing some important points when we look at data to build back better. So on the next slide. For me, the most important is to place persons with lived experience, of course, at the center of everything, and to recognize us as key partners in everything. And with that comes effective lived experience engagement. And that again also comes with considering diverse perspectives and experiences of lived experience, and also diverse backgrounds, so that we are truly diverse and global, and considering all people's experiences, no matter from where they come, their age, their gender, their culture, and so forth. And effective engagement is always based on empowerment, which for me is not all of us with lived experience are researchers or academics, but we can add so much value and provide so much valuable information that it's important to meaningfully engage us, but empower us to meaningfully engage. And then partnership, of course, and trust. And the element of trust must come with no power imbalances, to see us as equal partners, and to respect us for our experiences and also what we add or bring to the table. And then we all know mental health or mental health conditions affect every aspect of your life. So it's important to really have a multidimensional scope of an individual, but also of the context in which they live, work, or socialize, actually. And I think we often focus very much on the challenges and needs, and I think we mustn't miss the new learnings. I can actually mention examples during COVID. We had a bit of a discussion in the peer network with our peers, and there are so many new coping strategies and things that we actually discovered by ourselves while dealing with COVID and managing our mental health. So I think we also need to look at that and see how we can incorporate that into practice. And then meaningful involvement in response strategies, especially now during COVID. That is something that I actually see that's been missing. I don't think countries have really effectively engaged with lived experiences in developing response strategies and really making sure that those are aligned with the needs and challenges. And then I think what also where lived experience can be extremely valuable is involvement in translating research and evidence into practice. And that means right from policy development, right to methods of strengthening health and mental health systems to improve access, quality, and to make sure it's person-centered, and of course considering social determinants, the person being an individual, recovery focus, and of course, human rights threading throughout. And I think Shaker actually touched on this. What we offer is these policies, if financial and human resources are not made available towards implementation of policy and plans, it is merely just words on paper. And I think that is often a very big problem. Next slide, please. Yeah, I think we all know kind of discovered what the impact of COVID has on people with existing mental health conditions. We've seen a lot of impact around access to treatment. For example, there's been disrupted and suspension of mental health services, medication shortages, which we see especially now in South Africa. It's a huge problem. Transport, public transport, that's been disrupted, so people couldn't really access services. And then again, we've also seen extreme value of technology in terms of virtual services like telehealth, virtual support services. But for many communities, especially rural communities in African countries, there's a lack of access or poor internet connection, so those people actually can't access those services. What we've also seen is people being afraid to kind of follow up at their health facilities or to collect their medications because they're actually afraid of getting infected at those health facilities where COVID patients are being treated. Okay, we all know there's been a lot of worsening of symptoms. People's been relapsing because of the increased anxiety, depression around COVID. And also we've seen a lot of suicide. The suicide risk has been there. A lot of isolation and loneliness. We know the increased risk of people with severe mental disorders, of getting infected with COVID, comorbid conditions, poor health, and cognitive problems is another thing. For example, memory and concentration, because now you have to remember a lot of things. You need to remember when you go out, you have to wear your mask, you have to wash your hands regularly. You have to do so many things. You mustn't touch your eyes and your nose and all those things, or keep your distance. And for someone with problems with memory and concentration, that is kind of almost a burden, if I can put it that way. And then physical distancing is another issue in shared living spaces like psychiatric hospitals or care homes. The impact on the economic instability, for example, the fear of the future, especially for people with mental health conditions who already find it very difficult due to stigma and discrimination to find employment in the first place. So their future now is a bit more dark because of this. Loss of income, again, is linked to access of treatment, especially where, for example, where there's medication is not available, especially in public sector, and the person needs to go purchase it privately. Most of them, especially those on social grants, aren't able to afford that. So what do? They rather go, it rather ends up in having a relapse, and a big part of your life is actually lost. And then the economic impact can also, of course, lead to homelessness. Next slide, please. Now, if we look at these experiences and what we see related to COVID, what I feel is important data to kind of collect from this is we all know the demand for mental health services is now much more, because not only people with existing mental health conditions are experiencing mental health problems as a result, but the general population. So the demand is obviously higher. And at the same time, where services are suspended or disrupted, that is now lower. So there's a big gap in demand versus availability of services. And then again, the access of virtual services. How is that impacting, and how can that be kind of corrected? In terms of mental health, I think it's important if we can look at the relapse rate, especially linked to COVID, the potential causes of that, suicide rate, both deaths as well as attempts. I also think peer support, especially during this time, has become quite valuable. Sadly, especially in low middle income countries, peer-to-peer support work is not really that recognized yet, as in developed countries where in many instances it's actually incorporated as a occupation and part of the mental health workforce. Only if peer support would have been available and part of the mental health workforce, I can just imagine during this time with COVID, so many people needing support, that would have made an enormous difference. And then we also know that substance use rates increased, and that goes, of course, with gender-based violence as well, or domestic violence. And I feel also, if we look at, especially in shared spaces, in mental health facilities or care homes, what measures have been taken to avoid infection risk. And for me also, if we're going to go forward, we know the environment within these facilities is particularly a problem because of, shared spaces, that's often overcrowded. So what are we going to do going forward? How must these environments be modified to be prepared, to protect people in these spaces? And then lastly, the unemployment rate, also the direct impact of unemployment. And lastly, the homelessness rate. Next slide. Just to consider other aspects to be included as some way into indicators is lived experience involvement in response strategy. Kind of considering, has the response effectively addressed the real needs and challenges of people with lived experience, and how and what can be done to actually align the response to actual needs and challenges, of course, of diverse populations. Diverse populations and people with lived experience in different settings may need different ways of dealing with COVID and different measures to be taken. And then I spoke quite a bit already about value of peer support, both formal, which is your peer-to-peer support work, and informal, where it can be also peer support groups. But now during COVID, we've seen a lot of more virtual forms of peer support work. And then unique learnings, as I mentioned in the beginning as well, to learn from the self-discovering of coping and management of symptoms that people with lived experience especially discovered or came across or learned about themselves over this time during COVID. Next slide, please. To build back better, I believe, can only be achieved through meaningful and authentic lived experience involvement. Lived experience can be involved, or should actually be involved, in various levels. And here we talk about research, not only as participants of research projects, but also to lead research projects, to collect data, disseminate the outcome, and also to implement, taking the evidence and implement into practice. And also to translate those research outcomes and then into policy, and also be involved from the development, implementation, monitoring, and evaluation of policy, in systems, the planning and strengthening of it, because lived experience can actually provide very practical, innovative, and cost-effective and efficient recommendations for systems to be strengthened and improved, because we are actually the users of those systems. So our expertise is particularly valuable around that. Stigma reduction, we know stigma is a huge problem and continues to be a huge problem. And again, involvement in contact-based education, which has proved to be one of the most effective ways of combating stigma, and also to do collective campaigning. That again comes in with partnership development. And lastly, service delivery. And then again, peer support work as part of the mental health workforce and to be part of the treatment team. We also have people with lived experience who are actually professionals, from psychologists, social workers, even psychiatrists. So just lastly, to end off, to say people with lived experience can really add value to all levels in improving mental health for all. Thank you very much.
mute button gets me every time. Thank you so much, Charlene. Another amazing presentation, and your comments around the richness and diversity of experience that's open to us if we meaningfully engage with people with lived experiences, I think a lesson that we just can't afford to forget. It was a really powerful message. And I was thinking as you were talking, picking up on Shekar's point about the importance of reports being understandable and easy for policymakers to think about how they'll translate them into practice. I think your ideas about emphasizing the value that people with lived experience can add to translating ideas into practice is a really important one not to forget. And you so Shekar had the budget and burden gap, and you had the demand and service availability gap. So I think there's a really strong theme coming through about the gaps that we really need to be addressing with mental health services, and the importance that the data can help with that. Oh, it's really great. I've been reminded by our very slick communications team to remind you about the question and answer. They're forcing me to do some multitasking. So they're coordinating all the questions that you put in the question and answer and sending them to my phone via WhatsApp. It's a high-tech operation, this one. So please put your questions in, anything that you want to know more about from Shekar or Charlene, and we've got Yvonne and Oye coming up next. So please put in your questions and we'll do our best to get to them once we've gone through the presentation. So we're halfway through. It's now over to Oye. I'm really looking forward to the next two presentations.
Thank you very much, Tim, and thank you and also to Charlotte for inviting me to be a part of this webinar. As Shekar mentioned, I think it's an important topic, especially at this time. In the next minutes, my aim will be to give a brief description of the current state of things in regard to health information management in some low and middle income countries, as we found them in a study that we did recently. As we can see, during this pandemic, the use of data, especially relating to health information, has really been brought to the attention of the public. That an unprecedented use of health information to track infection status and trend. So we hear this phrase all of the time, flattening the curve. And so what curve are we flattening? Of course, that's got to be based on some data, and where is that data coming from? We do know that there are some problems about some of the data coming from many of the countries because of the way that they have not sort of been not really up to stay in terms of collection of mental health data. So people are becoming aware about current inadequacies, that especially whether they can trust the data on infection and the impact on health in general, as well on mental health in particular. People ask the questions, are mental health conditions increasing? But we can't answer that question without data. And that's also part of the awareness that in fact something is indeed wrong with the current state of things. Next slide. So, but indeed, next slide, please. We do know that health management information system is actually much more important than just collecting information on COVID, that it provides information on treatment needs and resource demands on the health system. It allows for us to be able to make well-informed policy and planning and health planning. So a good information system will be reliable and timely, as Shekar has mentioned, will be actionable as well, and of course will be accurate. Indeed, Sobon described a health management information system as a set of components and procedures organized with the objectives of generating information, which will improve healthcare management decisions at all levels. So it's not just information for for the sake of information is actually to serve the purpose of improving healthcare in all jurisdictions. Next slide. Unfortunately, next slide, please. Well, in low and middle income countries in particular, because of the really large treatment gap, again, as highlighted by Shekhar, there is a particular need for a very efficient health information system, which will help us to track trend of need. Is need increasing or decreasing, as I just mentioned? Mental health conditions increasing as a result of this COVID? What kind of service uptake is being impacted and how, as a result of what's going on? Again, Charlene mentioned that aspect of it in terms of the impact of the pandemic on the provision of health care. The cost of health care, quality and impact of care. All of these are issues that are very germane to bridging the large treatment gap for mental health conditions that exist in low and middle income countries. And it's indeed because of all of that, that collection of information on indicators is an important aspect of the world of the WHO Mental Health Action Plan, which sort of set a target for countries, for 80% of countries to collect and report a core set of mental health indicators by 2020, which is this year. Whether in fact countries are already doing so, it's open to question. Next slide, please. Unfortunately, the current state of the current situation in many countries, it's not particularly encouraging. Health management information system policies are often lacking. There's a gross limitation in human resources. Very strikingly, experts in information system are very uncommon in many of the countries, and most use untrained and poorly supervised health staff to collect information. And some of these staff do not actually collect very accurate data. As Shekhar mentioned again, it's actually quite a disservice to the system to have any information that is coming in that is inaccurate. And unfortunately, many of these collection ports are limited to central and regional levels. So we don't actually know what's going on at the primary care levels, the level that is closer to people and where we should be able to track uptake of service. So the mental health indicators, when they are collected, they are usually very limited in scope. Many times only what's collected are disease categories rather than a range of other indicators as highlighted by Charlene that will be very useful for building the health system, building them, and of course also building them better, as she mentioned. In fact, some of the disease categories that are often collected are also non-specific and fairly uninformative. Sometimes you get a category like behavioral disorders, which in fact doesn't tell you much about what kind of mental health conditions we're dealing with. Next slide. So what is really the problem with collecting mental health indicators, as we have found in many of these countries, is that they already complain about indicator overload. That is, some of the information that they collect for HIV and for many of these competing other programs not allow them to have a room for mental health. And they say, of course, that these indicators are already very long and take a lot of their time. And so these competing priorities sort of squeeze out mental health. And they complain, of course, about inadequate resources, including human and materials that I mentioned. But I think the overarching issue really is poor political will. Policymakers not really giving sufficient attention to mental health. I talk less of talking about collecting indicators about its profile and use and response to its burden. As I mentioned, the primary care level is the really important level where we need to be collecting such information. But unfortunately, many of the providers at that level are not not properly trained to identify mental health conditions. So if you don't identify, you cannot code correctly. And so there's a big gap in terms of the information that we can expect from that level of care. Next slide. So we need to be able to be thinking about how to make desired change. And we need to provide evidence about which mental health indicators can be of value, that can be actionable, that can be timely, and that can be accurately collected. And this is what we have sought to do in the study that I'm going to describe some of its results to us now. Next slide. Next slide, please. So we designed a study as part of the emerging mental health system in low and medium income countries. Before that, please, the previous slide. The previous slide, please. Yes, so we developed a set of indicators using the Delphi study methodology, which we conducted across 93 countries, from many of them being in low and medium income countries. And we tested the derived indicators in 5 countries listed on this slide, among 272 health providers over 9 months, and indicators are listed on the slide. So we wanted to know about the type of diagnosis they encounter, the severity of the conditions, the functioning of the patients, the treatment that they gave to the patient, the referral system, the follow-up, where follow-up was provided, and also payment for services. So we wanted to know a bit more than just diagnosis. We wanted to know about the operation of the health system as well. Next slide. What we found was quite encouraging. Next slide, please. We found that the indicators really did perform very well. There was 78% in terms of the level of completion, which was really quite encouraging. And we also found that this was not just that people were collecting the information, but in fact that that was being done accurately, which, as we mentioned before, this is an important issue in terms of the accuracy of the data that you collect. We found that the users actually improve over time. The more they use the indicators, the better their performance turned out to be. And we try to find out what their views about the use of these indicators were. And we found that they were generally very positive, both in terms of their assessment of the importance of collecting such information, the ease of use, the usefulness of the information being collected, the only exception being for functioning and severity and cost. They were not particularly sure whether those kind of details were very useful. Of course, that's a reflection of the current state of things with the health system, that people were not really quite convinced that some of these other indicators for health system functioning or performance might be particularly useful. They've generally found indicators to be of need, that were very necessary, and they expressed some confidence in the use of these indicators. The very important limitation or very important caveat that we obtained from the users was in terms of time. They were very concerned about whether this could be done in kind of routinely, in terms of fitting this into their routine duty, which goes to the point about having dedicated staff to collect this information at all levels of care, and not leaving this to healthcare providers who are already overburdened with the provision of care. And so in planning to roll out the use of indicators for mental health, adequate provision ought to be made for staffing level. Next slide, please. Next slide. So the evidence we found from this study is that mental health indicators can indeed be developed and that are acceptable to users and relevant to improve mental health care, that are actionable and that can be timely and accurately collected. We found that healthcare providers can be trained to reliably collect the data, but like as I mentioned, that in fact, this kind of process ought not to be left to those who are at the point of providing care. There should be staff that are trained to do the collection of data at every level of care. We think that this requirement for adequate human resources is a particularly important one in order for this to become some kind of a routine exercise that is done across these countries. But it can only be done when the political will is there and that gives adequate attention to mental health issues, which of course is also a reflection, it's reflected in part of the low budgetary allocation to mental health and the low attention generally given to mental health in many of the countries. So that's the summary of our finding. It shows that mental health indicators are necessary and that we need to be trying to develop human resources to have a reliable and efficient collection of such indicators. Thank you very much.
Wow, thank you. Oh yeah, that was amazing. Again, it's almost like you guys have been plotting behind the scenes to coordinate your presentations. It was fantastic to see you picking up on the themes that Shekhar and Charlene have already talked about, the importance of indicators. And what an amazing study. The scope of that and the findings were just staggering. And again, to underscore the importance of adequate training, I think the point about that Shekhar almost began with in terms of the poor quality data and your points about if people aren't trained adequately, they're not going to be collecting good data. If they don't have proper resourcing and the necessary time, the quality of the data is going to be extremely poor. And it's very concerning that at the primary care level where this stuff should be probably happening the best, it's not at all. So really powerful presentation. Thank you so much. So that's 3 out of 4. Please get your questions in. My WhatsApp number has been running hot. It would be great to have some more questions now, where I'll hand over to Yvonne as our last presenter. Over to you, Yvonne.
Hi, everyone. Hello, everyone. It's a pleasure to be with you. I will be discussing an important topic, the inadequacy of mental health data, as well as the lesson we learned from COVID-19 regarding policy and planning. Next, please. I would like to raise an important issue. Mental health is often neglected. Despite the enormous burden of mental disorders on individuals, family, society, health system, and the community, and the economy, mental health care remains a truly neglected area of global health policy. Next, please. So this leads to a huge gap when it comes to research in global mental health. More than 27% of countries do not have a system for capturing, for collecting and reporting mental health information. Next, please. On to mental health impact of COVID-19. Mental health problems such as anxiety disorders, depression, and suicide were seen to increase during and following pandemics such as COVID. In addition, restrictions of traveling during COVID and avoiding services because of fear of contracting the virus decreased mental health service access. Rwanda Mental Health HMIS data of March to August 2019 versus those of March to August 2020 now show serious decline in numbers of people who went to seek mental health services. This decrease of consultation for mental health during COVID-19 may predict that mental health problems are likely to increase in community affected during the pandemic. Next, please. These graphs show the bars in blue show the consultation in our health facilities for the year 2019. You can see the decrease for the year 2020. This can be attributed to the isolation, the solitude, and depression, all understandable measures put in place to prevent people from being affected by COVID-19. There is also all those measures discouraging people from visiting health facilities, but also just the fear of contracting the virus. Next, please. Another implication is the increase of attempted suicide as reported by Rwandan health facilities. From the year 2019 to 2020 now, you can see an increase of reported attempted suicide cases. Next, please. So this leads to a crucial need for data. All these issues require national, regional, and international strategies to capture indicators that are important to monitor the mental health impact of COVID-19 and then inform policy and planning. Next, please. What do we do specifically in terms of data capturing when it comes to surveillance? We need to conduct a nationwide need assessment and indicator survey to determine the impact of COVID-19 on mental health. Also, we need an in-depth qualitative interviews with people with chronic mental illnesses and their family to understand the way they cope and the challenges they are facing during the pandemic. Also, an in-depth qualitative interviews with mental health care providers to understand how they have addressed or adapted to the challenges generated by the COVID-19 pandemic. Next slide, please. How can we translate data into care and treatment? We'll need to use the survey findings to generate new guidelines or adapt the one we always have for delivery of mental health care and psychosocial support packages and service for resilience of individuals, communities, and healthcare system to cope with socioeconomic effects of COVID-19 outbreak. We need to strengthen delivery of uninterrupted community-based mental health services and international collaboration. Thank you for your attention.
Well, thank you, Yvonne. Another really powerful presentation, and so great to see you finishing on what we could do if we had good data in terms of international collaborations and generating new guidelines and so on. And again, another really great endorsement for the importance of indicators. So it's been 4 fabulous presentations, and we can now move to some questions. So the job of the panelists isn't over yet. And I think at the moment I've got, just to give the panelists a bit of forewarning, I've got 2 questions for each of you coming through. So let me maybe go one each to begin with. So Shakar, over to you. You talk about the dangers of incorrect or inaccurate data. Could you expand on how researchers can better regulate the collection and use of mental health data to improve the quality of policy and planning?
Sure, Tim. Very interesting and very important question. There are at least two kinds of data collection exercises that we could think of. One is routine data collection that is collected as a part of services, as a part of routine data gathering exercises, which all governments do, all health systems do. And as we explained earlier, for the area of mental health, that is especially weak, because mental health indicators are often not part of the routine health information systems. And if yes, those are the wrong indicators. So I'm aware about a lot of African countries collecting data on how many patients were admitted in mental hospitals in a particular year, which is a very small fraction of people who receive overall care, and that is a small fraction of people who need to receive care. So that is an example of the data that is not quite useful. The second stream of data collection is by focused research or monitoring exercises, which are often led by researchers. And I think that can also be extremely useful. And in fact, OA could perhaps explain better than I will be able to do, because there is an exercise called the National Mental Health Surveys, which actually has been done in Nigeria under his leadership. And that gives a population level prevalence and incidence figures on all kinds of mental health problems. And those are extremely useful for 2 purposes. One, to tell the government and health planners about what is the likely use of your services. What should you plan for? And second is, which segments of society are affected more versus less, in terms of age groups, in terms of the regional balances, and all of that, which can be extremely useful. And so that is an example of a researcher-led exercise, which could be extremely useful for these purposes. I'll also like to give an example of exercises which may not be that useful, led by researchers. Hospital case studies are useful for practice in a limited way, but sometimes are picked up by policymakers as a ground for policy making, which is actually a wrong use of those. So some of the rare conditions attain and invite a lot of attention, because they are in some way fascinating, but are far removed from the actual public health impact of mental disorders. So those are my initial thoughts, but I'm sure other panel members will have more examples to give.
Okay, terrific. Thank you. That was a great response, and I'll get back to you soon, but I'll move to Charlene now. There seems to have been an increased focus on mental health during COVID-19, but often directed at new mental health conditions appearing in otherwise healthy individuals versus the exacerbation of conditions as you presented, Charlene. How can we, so this person's asking, how can we use data and or those with lived experiences to help steer the conversation towards those who are more at risk?
Thank you. I hope I'm understanding this question correctly.
Yeah, me too.
I think for me, if I look at, I think both aspects are important of the impact it has on people with existing conditions, exacerbating their symptoms and making things much more difficult. I always think that's quite an easy one to really get because those individuals already receive services to some degree, or those who do. But then again, if there's just so many variables if you think of it, then again, those who now all of a sudden, who are now newly experiencing mental health problems, if I can put it that way, but may not necessarily come out and acknowledge it. But in my personal experience from interacting with people during this last time, people who never ever communicated about or spoke about mental health problems or any difficulties they experienced, all of a sudden everybody's talking about how COVID's impacting on their mental health, anxiety they experience, depression, frustrations, all those things. Yeah, so I think I might have lost the question, the core part of it, but I think that's part of my response. And I think, okay, maybe I can add to that and just say that I think during this time, maybe this time has really highlighted and kind of pushed for people to be open and talk more about mental health conditions and their own difficulties. And I think we can perhaps draw quite a lot of data around that. And from people, and I think especially people in the workplace that I've seen, there's quite an emphasis now around mental health. I don't know if that is answering the question.
No, that's great, Charlene. And I think, you know, as awful as COVID-19 has been and continues to be, I think the perspective around looking at the opportunities and the learnings that are also available is really valuable. And that, I think you've done a great job of highlighting that. Oye, over to you. It seems that to develop a well-functioning HMI system, it takes time and much cooperation. What can be done to mitigate the short-term challenges of dysfunctional or non-existent HMI systems in LMICs? Just an easy question for you.
Well, yeah, it all comes back to policy attention. Whether we're planning for a short-term way of addressing the gap, or we're thinking in terms of a long-term solution to the problem, it really has to do with with policymakers, decision makers, being ready to give sufficient attention to mental health issues. In the short term, as we showed in that data that I presented, we can have healthcare providers at the various levels of care collecting collecting information about on the patients they see. Along some of the indicators that I mentioned, of course, those are not exhaustive, but these were the ones that we came up with through that Delphi process. Some countries might find some reasons to include or exclude some of those indicators in their system. At And the good news is that we found that people can be trained to do this, but it does take time. It does eat into their time for doing other things. And also, as I indicated, people were quite concerned about the length of the indicators when you have with a variety of other programs wanting them to collect information at those levels of care. So the policymakers have to be mindful of that and, of course, address that in terms of providing for sufficient human resources to do this. In the long term, the best way of doing this is actually to have people who are trained to collect this information at the various levels of care. I'm always very, very careful about advocating for new layers of staff because I know that policymakers always frown and wince about that once you begin to talk about that. So that's the reason why I think the use of existing staff in terms of being able to provide adequate, timely, and reliable information. Indeed, that would be the bedrock of any kind of health management information system in order to be able to track what's going on, in order to be able to tracking. I mean, for example, we're talking about whether mental health conditions are increasing during this COVID. And one basic way of doing that will be to see what's the rate of identification or the rate of patients identified with mental health conditions at those levels of care. Is it increasing? But they can only do that when they have been trained to identify those conditions, and they also been trained to track and document this. So this is one way of addressing the issue in the short term.
That's a great response. Okay, thank you so much. And there's just no getting away from the importance of the political appetite or the political will to make a difference, is there? It's incredibly important. So Yvonne, a question's coming for you. I liked how you referenced strengthening delivery of uninterrupted community-based mental health services. Rwanda is known for its notably strong community health worker network. Has this been successfully leveraged throughout COVID-19 to support those suffering from mental illness?
So we managed before the hard period. We are now struggling with COVID-19. We managed to train more than 55,000 community health workers on common mental disorders, epilepsy, and drug abuse related mental disorders. So it would be important to conduct the survey I mentioned to have an idea of the kind of mental disorders people are suffering from due to COVID-19, and engage with our community health workers so that they become active partners and stakeholders in the management of mental disorders, but also preventing people from severe mental disorders. Also make sure our people with existing mental disorders are utilizing mental health care services in a safe way. Thank you.
Excellent. Thank you, Yvonne. So back to you, Shakar. Okay, you speak about the global health burden versus development assistance in low-income countries. Is there any data to show whether development assistance has been sidelined towards COVID efforts in low and middle income countries, withdrawing critical funds from mental health services?
Again, a very good question.
Mm.
In short, we have no evidence so far that this is happening, but this does remain a potential risk. But the risk is much larger than just the international development aid. The risk is also about national budgets being fully utilized for the healthcare of people who are getting infected, as well as buying vaccine and other things. So there is a real danger that even the small budgets that are going into mental health right now might be compromised and might be reduced. But I would also like to touch upon another question, which I see on the question and answer on the financing, which is related to obviously this. I have three points to make on that. One is that to increase financing, eventually one has to increase the mental health budget within the health budget of countries, because there is no defense on low and middle income countries spending less than 2% of their health budget on mental health, while the needs are much larger. So that remains the most fundamental point. But yes, some countries might need international assistance, which is necessary as a kind of seed funding or as a kind of stimulatory funding, which has its use. But also, I think the other point I want to make is that it's not only that we need more money, we need to utilize the money more efficiently and effectively. So we do know that a large number of countries spend 80% of their mental health budget on mental hospitals and institutions and only 20% on community care. This needs to reverse, because the effectiveness of what you spend on hospitals is so much smaller. So that is the use of monies that need to be better and smarter. And finally, my last point, that there is a vast potential of using less trained health workers like general doctors and nurses, who cost much less than psychiatrists and psychologists, who can even now deliver 60 to 70% of all care, and trained peer counselors. Charlene will, I'm sure, very much agree with me, who can really assist, and there's no dearth of them. So we need to have more investments, but we also need to have smarter investments to improve the quantity of care delivered and also the quality of care delivered. So these are some of the ways that some countries have very effectively used, and we need to really improve that. I would also like to mention examples like the friendship bench, which has actually arisen in Africa, in one of the poorest countries, and is now being tried in New York and some other cities. So these are the low cost but very effective mechanisms that we need to utilize. And these are some answers, and Africa has a lot of potential for innovations on that. Thank you.
Oh, thank you, Shakar. It's such an important point to dwell on, that it's not obviously getting more resources is an important part of the equation, but working smarter is also a big part of it, and tapping into people who can work efficiently and effectively, I think, is such an important point. It was wonderful to bring in the peer networkers again. I think they're a really underutilized resource that we could be tapping into much more. So speaking of peer networkers, back to you, Charlene, and the question is about that. You mentioned the value of peer support in your presentation. How can different institutions, those not otherwise involved in mental health data collection, so how can they support formal and informal peer support by integrating this into their ways of working?
Yes, I think there are many people with lived experience. Sadly, what we see is that I think training is important for formal peer-to-peer support work. Unfortunately, we see those trainings happening mostly in developed countries. I think there's a project outside. There's a few now moving to low and middle income countries, actually. And I think that's important to have that accreditation, because trust me, in my experience, where I previously trained peers, to kind of do some form of peer support, and went to clinics where the psychiatric nurse said to them, but you're not qualified to do that. I think, again, stigma plays a role. You know, the undervalue of the value that peers can bring to service delivery. I think with accreditation, that can actually change. That actually gives them that level that they are equally capable of performing that service. And I think it can just add. We've seen research already showed that there's reduced need for hospitalization. That's again linked to cost saving, reduced need for a reduced dosage of medication. Not only there's benefits for the peer supporter, but also the person receiving peer support, but it's also got value for the person giving the support. So you feel a purpose. So overall, it's got really long-term benefits. And even if you look in a continent like Africa, where unemployment is enormous, having a purpose also kind of help your well-being and your mental health. So then again, the economy will benefit if peer support workers are actually employed into service delivery. So there is no downside to it. Well, however way you look at it, well, the entire country system benefits from it, really. But I think we need to address that. There need to be training available. The peer network is actually planning to develop an online peer support training platform, especially adapted for multicultural context. I hope that answers the question.
Yeah, that's great. Wow, and what a fabulous initiative, Charlene. That would be amazing to see that develop. And it actually ties into the next question for Oye. At the end of your presentation, you referenced how healthcare providers can be trained to reliably collect data. What training programs or initiatives are already in existence or available virtually for healthcare providers in low resource settings? And could academic institutions play a role in this training?
Thank you very much. Well, I'm not aware of any training program online that can, I mean, there are two levels of training we're talking about here, actually. There is the training that healthcare providers need to have in order to be able to identify and treat common mental health conditions at various levels, especially at primary care level. And we know that's a huge, huge problem. And that's part of trying to resolve or to address that problem is the reason why the WHO designed the MH-GAP intervention guide to help non-specialists to be able to do that. That's one level of training. That's really in terms of providing care. The next level is in terms of completing or collecting information based on the indicators that have been identified or designed to track mental health conditions presenting at those different levels. That will require different kind of training. Now that in part will require the indicators to be developed. The ones that I showed are the ones that we tested, and I think they are readily, they can be used, they can be adapted, but they certainly seem to have functioned very well. The training that is required is basically for people to be able to complete the required forms correctly, and that's not really a big deal in terms of what is required to do that. Of course, that has to be like I keep more mentioning, this is part of the overall information system that indicators will then feed into the national grid for information, and so that it can then be able to, they can then be able to track what's happening for mental health conditions and their treatment. But in terms of the treatment for the former, in terms of identifying and detecting, of course, there are quite a variety of ways one can acquire that. At the second level of training will require different approaches. And of course, universities and research centers can be very useful, especially places where we have specialists. would be very useful in delivering either of those two training. Thank you.
Thank you. Another great response, and really important. It would be, as with Charlene, fabulous to see some of this training being developed. We've only got a couple of minutes left, but Yvonne, I really want to get this last question to you. What practical measures can we take to improve access to mental health care in settings where virtual means are not an option, such as rural or remote settings? Wow, another great but very tricky question. Over to you, Yvonne.
Can I say that having mental health care among high priorities in our country is already something we can be proud of. Access to care has been made possible by training healthcare providers from the health center level. So since 1995, we made sure we have at least one general nurse trained in mental health care. So receive, they can diagnose, they can give care, and refer to the upper level in case of need. And progressively, with the training of our mental health nurses, now we have psychologists, we have mental health nurses at the level of health center. This is one thing. But another thing is utilization of those services, because you know that mental illnesses go with stigma, go with other beliefs that can prevent people from seeking care, even though services are available. We have another big component in our health policy, mental health policy, and this is public awareness. So we keep raising awareness by using every channel of communication to educate about mental illnesses, to educate about self-care, peer support. And I mentioned our community health workers. They are a good part of our healthcare system. And when it comes to a special category of genocide survivors, among those genocide survivors, we have high prevalence of depression and PTSD. So we had no other choice than building capacity among the organization we have for that particular category. And those also are our main stakeholders. They are doing a good job down in the community. So we keep training people in the community. We keep raising awareness to connect our people to healthcare services and other mental health support. Thank you.
Thank you, Yvonne. Another rich and really detailed answer to some fantastic questions. So we are out of time now. Unfortunately, we're going to have to wrap this up. I want to say a final thank you to our 4 incredibly knowledgeable and talented presenters. I've learned heaps, and I'm really looking forward to dwelling a bit more on the information that we've had presented to us today. The next webinar in this series, so we'll be talking some more about data and how it can be used to improve mental health services on the 16th of December. So keep an eye out for that webinar. We do need to finish now. And as I said before, this webinar has been recorded and will be distributed on the usual UGHE channels. So keep a lookout for that.